And you see that our title that Maurice asked us to speak about is the role of digital technologies and materials in a very specific brand, in full arch implant reconstruction. And so you are seeing on the right side of the screen a video of an elaboration of a full arch reconstruction. Obviously, this is the same slide that we always put at the beginning of our last few months presentation, because the hottest topic in digital dentistry now is, can we become predictable? Can we close the circle in the full arch? Can we become completely digital? And I always use this slide because I say that it would be a little bit inappropriate starting speaking only about full arch rehabilitation in digital dentistry. We need to have a learning curve. And what we're going to try to do in the first part of the presentation is to share together with you our learning curve on digital dentistry, on the cases that we did, step by step together with my brother, and seeing and trying to share with you the benefits that we are obtaining in our daily clinical routine in this great field of dentistry.
So we divided our lecture into three main parts to share with you an overview of what is our experience on digital dentistry, focusing especially in how has been the evolution in full arch reconstruction.
And this first slide is probably the most important one because it's telling you what is the digital workflow all about. We do have like 3 steps that starts from a data acquisition, and we have a lot of instruments, we have a lot of tools already now to acquire data. Don't think only about intraoral scanner, but think about digital cameras, think about CBCTs, think about CAD scanner as well. Also those helps us to acquire data that then can be elaborated with softwares like the CAD software, in where the dental technician becomes the CAD designer and produce and then send everything to production. That is the third step of the workflow with milling machines, for example. So the goal of modern dentistry is try to become completely digital from A to Z in every single case that walks in our practice. Obviously, we don't have to forget this triangle in the middle of the slide, because time, our clinical time and our dental technician time is very important, but most importantly in 2016 is our patient time. We are living in the patient-centered care era, so we should focus not only in our cost but also in our patients' cost. And the goal has to be that, yes, we have to close the completely digital workflow, but keeping the bar of the quality at the same level or increasing, raising this bar higher.
But don't forget that in the middle of the triangle, it must always to be considered the patient. Always.
And here we are discussing more on prosthetic digital dentistry. So you see 3 instruments, 3 tools that are exactly explaining to you the digital workflow. We do have an intraoral scanner, so computer-aided impressioning. We have a CAD software and a CAD scanner in this case, and a milling machine. So acquisition, elaboration, production, okay? And as you see here, we have like 3 instruments that are used not only by clinicians, but also by dental technicians. So what is important? To share everything, to have the same knowledge together with your dental technician. So working as a team from the very beginning, becoming an expert in what your dental technician is doing, and your dental technician should be an expert on what you are doing.
That means that digital technologies permits to standardize the working processes, controlling all the different variables present in the traditional workflows.
Yes, this is very important because let's think, for example, about the intraoral scanner. If you're using if you are expert on using it, if we are competent on what we are doing, and we have a system that is consistent, we know in advance, before touching the patient, how accurate we can be, because this instrument can be, let's say, 70 microns accurate. So we have a quality control up front, and so, as Alessandro just mentioned, we are standardizing the process. But obviously, digital dentistry, in our opinion, is all about traditional knowledge, because they are giving us a lot of benefits, but we should know how to use them, because we have to prep properly our teeth, we have to manage properly our provisional restoration because we don't want to have any bleeding or saliva in the way, because if not, any intraoral scanner won't detect anything. Okay? And same thing, if we want to use new materials such as zirconia, we should know, and our dental technician should know the optical properties and the strength properties in order to design and customize the framework design as you are seeing here in the left side of the screen.
We should then ask ourselves when, where, and how the new technologies are being incorporated into the treatment plan sequence. But especially we should ask why. Why? Which kind of benefits the new digital tools and the new materials are bringing every day more in modern dentistry?
And does new technologies are affecting treatment sequences, or are they affecting the working process steps? Those are the four main questions that we're going to try to answer together with you today.
By looking at this slide, it is clear how the advent of the new digital softwares has been the game changer for our technician, who achieved a total control on all the measure variables, especially in complex cases such as this.
And so they had an increase in quality, an increase in efficiency, a better management of their dental lab. And we had like the renaissance and introduction of new materials. And when we discuss about new materials, everybody thinks immediately to zirconia. But don't forget that we have a lot of different new materials, such as, for example, PMMA, that is a great material for provisional restoration, for example.
Moreover, raw industrial materials have intrinsic mechanical and physical properties which are higher than the traditional material we have been using in our daily routine.
And we discuss about dental technicians, but let's think about us. Let's think about clinicians and take these two pictures. Here we have a clinical situation in where we are ready to take the impression, and here we have our digital impression. But look carefully to this slide. Is the image on the right only the digital impression, or live, in real time, I'm sending to my dental technician the master model? So I'm saving how many steps in my working process? That's the key to understand the importance of thinking digital. That's why we have to get in this train.
Yes, Guy, try to think that we know in advance the master model in precision, which would be the same for the opposing arch, obviously, and the bioregistration, since are taken with the same instrument.
Yes, we are basically, once again, standardizing the process. And to make a short story simple, long story short, just look what Alessandro, since he's the older one, was doing in the 90s to document cases. So taking pictures with camera, calling the dental technician that maybe was with another doctor, and maybe videotaping the patient in order to get dynamic registration. Try to think what I'm doing.
And okay.
In 2016,
everything is inside in only single device.
And that's exactly how digital dentistry is affecting our working process steps. The same thing as the iPhone. Yeah. Nothing has changed.
So why should we start using the optical scanning? It improves the communication with the patient and its comfort, for example.
But we have the possibility to adjust any mistakes live, because we see in the screen if there is an undercut, so we can re-prep and then rescan. It's a great communication tool for our patient. We can increase and standardize the process, as we just said, and we can establish new treatment protocol. This is exactly what we're going to see today.
Intraoral scanning can already be considered a reliable clinical reality. But like every innovation, we should be familiar with the technology which is behind our system. The new working position, training the assistant to follow the proper scanning strategy.
And why scanning strategy is important? Because at the end of the story, we want to be accurate. We want to be expert and competent on what we are doing. And accuracy, especially when we are talking about digital dentistry, is a not topic because we are discussing about, and we have to define what is accuracy. We are discussing about accuracy on a single tooth or on a full arch. Completely different story. Let's say, for example, and let's have a look to this article that was published in 2015 where, let's call it local accuracy of one single tooth. If we compare traditional and digital, we were on the same page, okay? And really, let's go back not only in the literature, but let's go and see the clinical reality, okay? Let's see the clinical reality of this second lower molar, in where obviously we had to improve retention. We had to change finishing line in order to get all the requirements that we need to deliver a fine prosthesis. Yeah. But then we had digital dentistry.
Vertical finishing line. The clinician's skill keeps playing a pivotal role. Proper tooth preparation, soft tissue, and provisional restoration management.
And the local accuracy of a single unit is great. And we had excellent marginal fit, ideal proximal contacts, fewer occlusal adjustments necessary. But most important, from the impression to this picture is one single passage, one single appointment from the appointment of the impression to this. So try to think how much time we are saving and our patients are saving every day.
A completely different ballgame is to speak about general accuracy. This one is especially interesting if we consider full arch impressions.
Yes, because we have to discuss about full arch implant rehabilitation today. And so try to think how important is to detect the proper position of the implants in order to achieve the passive fit. And how important is to get general accuracy, not local accuracy. That's the key to understand the full arch complex.
The proper management of each corrective therapy is critical as long as the strategic sequence of the treatment plan.
And this is a case brand new. We just finished like 1 month ago, and you see this is a case done on a natural dentition, upper and lower. You see that we managed to take like full arch implant rehabilitation. And what was the key here? The key was having the provisional restorations divided into 3 pieces. So we had the possibility to merge all the different files together, as you can see here, by keeping the provisional restoration in a posterior area and scanning the abutment in the front and opposite. That was the key. So that is the key of understanding the digital workflows, because we have to define not only the accuracy, but also the workflow. Those are 2 different completely different concept that we need to merge together.
The proper aesthetical and functional management of the provisional restoration is enabling us to copy and replicate it for a predictable final restoration.
And that's the final restoration that at the end of the story has to fit properly in the patient face. And you can see the accuracy and the nice blending of the white and pink aesthetic that we are able to achieve with the full arch digital workflows. And discussing about clinical parameters that basically are the benefits, the practical advantages that we do have. Prosthetic dentistry is obviously the greatest advantage, the branches that is getting the best advantages out of digital dentistry. We can combine, as we saw yesterday with the lecture of Rami, CBCT data for guided surgery, face scanner that still needs to be implemented. Orthodontics is already like the present. Digital dentistry is already present. But try to think to have the possibility of that last sentence. The ability to copy and replicate the provisional restoration with optical scanning in combination with monolithic material. That's because technologies and materials are going together all the time.
Today, we are doing exactly as Frank Celenza was doing more than 30 years ago. Copy the provisional restoration and replicating in gold, Frank Celenza, the functionalized provisional restoration. In our opinion and experience, implant prosthetic dentistry is where the digital revolution affected the most our everyday clinical routine. Consider all the variables related to the behavior of the different materials and the prosthetic tolerance, for example,
that we have in the traditional impression, because which impression technique do we have to use? Open tray or cross tray? Each of them come with benefits and limitations. The higher the number of implants, the most difficult it is to take an accurate impression. If we have angulated implants, it's even more difficult. And also here, we have our measurement tool. That is what? Is the impression copying. And if we want to take out, if we want to remove the tray from the mouth of the patient, this measurement tool has to have what? Tolerance, prosthetic tolerance that is clinically accepted, okay? And try to think in digital dentistry. We have instruments that they have, yes, accuracy, but they don't need tolerance, okay? And moreover, we know the instrument that we are taking, they scan, so let's say 70 microns, we know the measurement tool, so let's add 5 microns. We know the milling machine and the CAD software that together are 50 micron accuracy, and before touching the patient, I know that if I am expert, I'm competent, and I have a consistent system, I have 100 microns in accuracy. That's the advantage.
And the scan body that represented here are assembled in 3 pieces with 5 micron accuracy, round-shaped, to improve the scan captures.
Obviously, if we have more implants, we need to use a dynamometric screwdriver in order to torque them down at the same torque, so reducing once again the inaccuracy that we potentially may have.
Obviously, the traditional background is always key to recreate the proper hard and soft tissue volumes to be recorded with the optical scanner.
And we wanted to share with you this case that was the really first case done in December 2009 with the prototype of the digital impression that we developed together since 2011. That was the really first case in where we started to get inside digital dentistry.
Now let's consider the benefit discussed so far, combined with the new materials available today.
Yes, because we discussed about digital benefits, but don't forget, the new materials are blending exactly in this triangle that we explained to you in the very first slide.
Thanks to this, we could work in a completely digital environment, avoiding passages being then more accurate.
And here we have one case in where obviously the traditional background is still playing a key role, because we have 2 completely different clinical scenarios that you have to manage, an annealed ridge and a fresh extraction socket. So you have to know how to place the implant in the proper 3-dimensional position, how to manage and to shape the immediate provisional restoration. After that you achieve primary stability. You have to explain to the patient how to clean, how to be compliant in order to achieve this kind of region where you didn't have any collapse buccal palatally. And only at this moment you can take the impression. So once again, traditional background is driving digital dentistry to obtaining benefits.
We are in the posterior area, maximum anticipation again, digital impression benefits combined with monolithic materials ones. 2 adjacent implants split together, and the digital system worked properly, providing us the needed passive fit. Things are slightly changing when facing an aesthetic area, obviously.
And obviously, once again, traditional background, diagnostic approach to knowing how to manage a central lateral incisor that is probably the most difficult clinical scenarios to approach in the aesthetic area. So collecting all the information and then strategic treatment plan. That's the sequence, the key, what to do, when to do, and how. Obviously, we can use, for example, DSD, as we discussed together today with Dr. Stanley. We can understand and communicate with the patient what are her issues, because she has to know, she has to understand which are her issues before to start. If not, she will not understand how much thing we did for them.
Positioning the implant correctly in the 3 dimensions of the socket and a proper management of the provisional restoration, as you can see, together with a combination of bone and connective tissue graft will permit to maintain the root profile and the interdental papilla of these very challenging cases.
And the combination of bone and connective tissue graft is a study and a protocol that we call surgical veneer grafting that has been recently accepted for publication together with Team Atlanta. And we think that in these kind of cases in where we need to maintain everything that we have could be a good alternative. But obviously you need to diagnose it properly before like starting touching the patient. And at this moment we are ready to take the impression. Okay? We are ready to take the impression, detect the implant position, but what Dr. Glackman said yesterday. Now, as soon as you remove the provisional restoration, the gingival tissue is going to collapse. And digital dentistry is helping us to do what? To improving also and avoiding this limitation. Because we are able to scanning the provisional restoration, critical and subcritical control, and transferring the exact soft tissue replica to our dental technician.
In fact, despite what we know about the gingival tissues, acrylic resin doesn't shrink. And thanks to the optical scanner, we can record the provisional restoration emergence profile, as you can see.
And another thing to keep in mind, digital dentistry you need to be constantly up to date to be on the same page on the evolution. So this was a concept that was explained in our book that was published also by a group from Bologna in 2015, but there was one but. Because yes, you could have taken that scan, but you didn't know there was only one software that was orienting the scan in the other different scan you take. And so the question was how we oriented without using geomagic. And we created this protocol that is called Simplified Digital Impression that we just recently presented the poster at the IJPRD in Boston, always together with Team Atlanta and Stephen Chu, in where we are explaining this technique, and this is another technique that is giving you an advantage, another benefit, another digital benefit on your workflow, on your portfolio, on your armamentarium.
Since we are working in an aesthetic area, we need a model produced in a digital environment for the technician to finalize the case.
Yes, we need a model because we have like also natural dentition restoration here. We have veneers, we have 2 veneers on number 21 and number 13, and so we need a position, we need a model in order to layer the ceramic on top. And if everything is done properly, the digital workflow can help you in bringing and conclude a full digital workflow of a central lateral case, but obviously the traditional background guided the treatment plan from the beginning to the end, and digital dentistry affected improving the efficacy and efficiency.
In these cases, we already today have a reliable full digital protocol, raising the bar in terms of quality and accuracy.
Yes, because what we want to show, the learning curve on maximum intercuspation cases in short span bridges is critical to understand the full arch rehabilitation. And we can tell you that really the efficiency and the efficacy of our daily clinical routine was improved in a great way.
So let's try now to enter more into the details of the full arch rehabilitation management and evolution of the last 12 years.
Since 2014, we are treating like full arch implant patient, and we are starting collecting data, and we treated 132 patients, 156 arches with 786 different implants of 5 different implant companies. But the most important thing of this slide is that we had only one prosthetic protocol that never changed. The surgical protocol was changing. Straight or tilted implant was not important for us. Was important the clinical anatomy of the patient, and then we were deciding what to do. That was the key in order to understand. And as perfectly Miguel Stanley this morning explained it to you, the best advertisement are patients, because if you treat them well and you make them happy, they are referring you a lot of patients, because in these 132 patients, we had 6 wife and husbands, 4
Only?
6, yes. 4 sisters, 4 couple of sisters, and one mother that pay the work for the daughter. So they are keeping referring patient because you are making them happy, trying to avoid what? Trying to avoid anything removable in their mouth. Okay? Increasing the quality of their life also during the treatment and not only at the end of the treatment plan.
Those are some of the articles published by our team with the positive surgical and biological survival rates that are also available to download on Dental XP.
And we were saying we are trying to avoid anything removable in the patient's mouth, so we keep teeth till the day of the surgery that are helping us in order to create a provisional restoration fixed or natural dentition. Then obviously, as I said, surgical protocol is different, can be straight or can be tilted implant. In fresh extraction sockets, sometimes it happens. We prefer iliad ridge. We prefer, you can use osteotomies sometimes because we need to achieve primary stability. The prosthetic components rational with the multi-unit abutment are extremely important for us because they're giving us a lot of advantages. The possibilities of using also less wide diameter implant. Tilted or straight for us doesn't matter. What is matter is the prosthetic protocol. So the surgical surgical guide that is prosthetically driven by the prosthetic evaluation that we are doing before the surgery, the implant transfer key that gives us the possibility to bring this patient from left to right and improving their quality of life from the very beginning. You see here, we have several restorations that are metal reinforced with acrylic and composite on top, and most of them are long-term provisional restoration. Long-term provisional restoration. That means that we can leave them also as a final restoration. Screw retain, long-term provisional restoration.
With metal reinforced.
With metal reinforced.
And don't forget the bone reduction. The bone reduction needs to be customized to the patient prosthetic evaluation done before the surgery and the chosen provisional restoration material. This is very important, not bone reduction
all the time.
All the time. Customized. By briefly describing these 4 cases, it will be clear to you how important the advent of the new digital software has been in the technician workflow, providing, for example, a faster workflow production and decreasing the difficulties on achieving passive fits. In one word, today we can achieve a better standardization of the procedures. This very challenging case, especially on a functional point of view, overjet in the upper left of the screen. Look, incredible. Especially on a functional point of view, restoring in 2003 with an upper and lower PFM mesostructure rehabilitation has been possible thanks to a very talented and skilled technician.
Yes, because in this case, the technician was able to overcome the difficulties in achieving a passive and predictable fit, maintaining uniform thicknesses despite controlling all the variables during the interim wax fusion. So great, talented, and skilled technicians.
Do you think that traditionally this accuracy was standardized between all the dental technicians? Come dice Tarno.
As Tarno say.
For me, no. For me, no. In this similar case, done 2 years after, something has changed. Thanks to the new CAD/CAM potential, dental technicians started to have all the major variables under control, customizing the framework design respecting volumes and thicknesses more accurately than the conventional protocol.
And in these two cases, we went straight to the implant head, but as we said, we always try to be up to date, and we add the multi-unit abutment in our protocol because they gave us a lot of big advantages, such as the one abutment one time. We are using them as a shock absorber because they are distributing better the stress. We can improve the passive fit, and we can deliver easily without numbing the patient the provisional restoration because we are bringing the connection more coronally to the soft tissue.
In 2009, thanks to the new materials which were available on the market with great optical and strength properties, are providing different alternatives to the dental team.
And obviously these materials were also created and studied in order to avoid and to overcome the problem of chipping, because in this case you have a rehabilitation with a framework, with a zirconia framework, and with on top single crowns and bridges of done in monolithic lithium disilicate. So you see, we were improving the materials but also our knowledge in digital dentistry, our knowledge and our dental technician knowledge. That's very important.
Same thing in this case, completed 2 years after, by carefully checking the occlusion. The occlusion first, the occlusion, the occlusion, the occlusion, the occlusion first on the model, and then in the mouth. We have been able to provide a monolithic occlusal zirconia restoration only for aesthetic reason from bicuspid to bicuspid.
And so what is important for us is for you to understand this table, this slide, because it's not only about the choice of the material that gives you only the initial strength, but it's really how you understand the stress distribution. We discussed about multi-unit abutment, so the knowledge of the clinician, the knowledge of the technician is very important. The risk evaluation of the patient, parafunctional patient risk profile that is high or low, is biomechanical risk profile that is high is completely different rather than a low one. And also by knowing all of these things, we can minimize our complication. We can have like a sort of damage prevention concept, but it's always as a team. Our dental technician, us as a clinician, and also the patient that needs to be compliant and needs to wear, for example, the night guard and clean the restoration.
Considering what Andrea just said, sometimes we have cases that are challenging in terms of material selection, like this case. Implants, teeth, anterior or posterior area, different biomechanical behaviors here. Variables that are sometimes leading us to choose different materials in the same case. So for this specific patient, it was chosen a PFM full arch on implants in the upper and a combination of feldspathic veneers and zirconia layer crowns in the lower. Getting more into the details, with another complex case management helped us discussing about some another digital possibilities.
Yes, here we do have like a partial dentulism case in the upper arch, as probably is the most clinical scenario to manage, because we have like implants, teeth, or pontics, and so completely different biological behavior in order to get like a final gingival proportion, for example, while in the lower we will go through a full arch implant rehabilitation. And from these very first stages, in this case that we treated, we started treating in 2013, we were able to involve some other digital possibilities. You know that now we can pass from a 2D evaluation of the DSD to a 3D evaluation, so we can do a digital walks-up also for these kind of cases that can start from the scan of the study model, or can start also from the full mouth scan of the initial situation. So it's up to you to decide when to become digital in your treatment plan. But you have to know that all of these things are today possible. Okay? From this evaluation, we can go through what? Thanks to the virtual articulator, so the new digital tools that nowadays we have in our CAD software, these digital articulators are simplifying those steps, and we can arrive to achieve a provisional restoration done in a completely digital workflow.
The lab technician has the total control of the major variables. Also in this case, he can design the new occlusal plane, for example, always double checking from where we started.
Yes, because look, for example, here we have the yellow, that is the new occlusal plane that we decided to bring more apically, and the gray color that is telling us where we started. So always double checking from where we started to where we arrived. And then once again, combination of new technologies, but always materials. This is a first provisional restoration done completely under a digital workflow in PMMA. So once again, remember, those are raw industrial materials. So mechanical and physical properties are much better than the usual acrylic resin that we always use. So we are raising the bar of the quality we are raising higher the quality bar.
In the upper arch, partial dentulism scenario, it was decided not to immediately load the implants, utilizing the first provisional restoration, obviously. While in the lower jaw,
as we said, there was a full arch implant rehabilitation. In these two cases, was 2 implants straight and 2 tilted. Obviously, the CBCT evaluation is critical after that you have the first provisional restoration in place. The prosthetic evaluation are critical because they guide you to create a surgical guide that is telling you how to place the implant inside the prosthetic volumes. And here you see the one model technique, that is the technique, the prosthetic protocol that we are using in all these cases since 2004, in where you see after that we place the implant, we are using the surgical guide that now becomes the impression tray by connecting all the different transfer after placing the rubber dam in order to protect what there is underneath. And when the composite that we are using, that in this case is ProTemp, we can remove all the complex and send it to the lab, in where she will start, our dental technician will start to create the provisional restoration on implants.
By following the one model technique protocol, the technician has all the aesthetic and functional information together with the implants position, multi-unit position, to start building the immediate reinforced screw retained provisional restoration, either in a traditional or in a digital way.
Yes, because we saw some traditional stuff, but let's see what is the digital way, because we can put we can screw down the scan abutment for the lab, scan the model, and obviously the lab technician has already scanned the provisional the opposing arch and the bite, and it can control everything digitally. The screw axes are there, the volume, the prosthetic volume thicknesses are there, so it can spend time in, for example, working on the function with the digital spatula, that is the mouse. Okay? And so once again, you will see here,
New technologies, but also new materials. PMMA immediate provisional restoration.
okay? This is another case, but just to show you that we can have different options. We just have to target what our patient needs, and then choose the option that we think that suits better. And going back to our case, this is the first provisional in PMMA in the upper, and the provisional restoration immediately delivered on the implants. And you see aesthetic and function are there because the provisional restoration is key to succeed at the end of the story.
With the second provisional restoration in the upper jaw, we can focus on the final soft tissue details. Here it was decided to push more buccally the soft tissue aspect of the left upper lateral pontic site, utilizing the ESE technique published by the Calesini group, an Italian team group, in 2009. The prosthetic project divided the arch within 3 cement retained pieces, 2 implants supported in the distal part and 1 supported on teeth in the front area.
And so we have 3 pieces. Why we cannot? Sorry. We have 3 pieces, and we can then take a digital impression. Obviously, we were in 2013, so we divided the arch in 3 in order, since in 2013 we were still not predictable on full arches, we treated this arch like they were 3 different bridges. But everything was there, so the digital workflow moved on, and we were able to send everything to our lab technician and look, the zirconia evaluation, the optical property of the zirconia evolution is incredible. It's been incredible since 2005. Not opaque anymore. Now we have this kind of translucency, so great optical properties,
and
but
great design.
And great accuracy.
We digitally copied the function, and now we are replicating it with the monolithic material, leaving only 0.6 millimeter for the layer, for the porcelain.
Each detail is important during the treatment plan, and so also the cementation phase. Don't forget, if you have the possibility to pack a cord around the abutments in order to remove more efficiently the cement.
And look at these 2 pictures. In the upper arch, we have implants, teeth, and pontic sites, which have completely different biological behavior, challenging the dental team to mimic mother nature in the partial edentalism cases.
And once again here you saw you saw a full arch and a partial edentalism rehabilitation, but once again we had a merge, we had an hybridization of traditional and digital workflow, because 2013, we were in 2013, and so also at that day we needed to have this hybridization in order to complete the workflow, okay? Let's see what can we do in the future. Let's see what can we do now, okay? What is the state of the art?
Let's now discuss which are the immediate digital future possibilities in full arches implant rehabilitations. The hottest topic in digital dentistry, in fact, is can we become fully digitally also in such cases?
And as we were saying at the beginning, we have to define that these 2 sentences are completely different. Scanning, one thing is speaking about scanning accuracy, another thing is speaking about the full digital workflow. Because we have a lot of digital scanner, intraoral scanner in the market that now are accurate. And they give us the possibility to be accurate also on full arches. The most important question is, do we have a standardized full digital workflow? Obviously, as we said, those are not the case to start. You need to be an expert, you need to be competent, and you need to have an instrument that is consistent in your end, okay? So you need to have a learning curve. That's critical, really. If not, you will not be successful and accurate in full arch implant rehabilitation. And what is the literature is telling us? we know that as in the traditional way, the higher the number of implants we do have in an arch, the less accuracy we will obtain. And also, what is accuracy? Because we spoke a lot about accuracy, but still it's not well investigated.
And it seems that landmarks are needed to be accurate, since mobile mucosa could interfere with the scanning procedure.
And this is the last article that came out in 2016, and I think it is very interesting because it's comparing the accuracy on full arches of the traditional impression material compared with 6 different intraoral scanners, not just one, but 6. And this, I think, what makes very interesting this study.
The scan strategy and the clinical expertise are pivotal to achieve the same accuracy obtained with the best traditional impression materials.
Yes, once again, scan strategy and clinical expertise. Because if you look in the first sentence, they obtain a higher accuracy in the conventional workflow. But as we said, experience, competence, and consistency are the 3 key words. And so, let's see, can we be full digital in this case?
The last case.
That's the last case of the day, and this part on the left side of the screen was the last case of the book. We finished with the provisional restoration, where we did like a upper traditional way of creating the metal reinforced provisional restoration and a lower digital workflow. Okay, and you can see here 3 parts of that treatment. But let's now focus here. We do have like 6 implants in the upper that are also integrated, 4 implants in the lower. What do we need to know? Scanning strategy. And also scan abutment. You see that they are in completely different position because computers are computers. So which scan abutment are you detecting now? If they are in the same position, they won't recognize it. So you see now clinical expertise in digital dentistry, why is important. Scanning strategy, how many scans do we need here? We need 5 scans. Upper provisional restoration, lower provisional restoration. And how this provisional restoration should be accurate, because we want to copy and replicate it. And then we need to take the scan of the eccentric occlusion. So 5 scans. So clinical expertise, so scanning strategy, those are going to make the difference if we want to be full digital in these kind of cases.
The software permits you to correctly match all the different files using only one common point.
Yes, because try to think, we took 5 scans and basically we have 1 scan over there, 1 scan over there, 1 scan over there, 1 scan over there, and 1 seated next to Huawei. And we want to match them all together, and we just need a matching software that by choosing 1 point, 1 reference point, will merge them together, giving us this image in where we do everything. We do have everything: screw-all axis, implant position, implant inclination, provisional restoration. That is going to be our starting point.
From the provisional evaluation in the upper right, phonetics, aesthetic, and function, the dental technician can elaborate and produce a prototype which will be tried in
and
to
remember,
the patient.
From here to here is completely digital. So the dental technician is changing things on the provisional restoration based on the video analysis, based on the picture analysis, but in a completely digital way. And then he's elaborating data and he's producing data.
The phaseball with the prototype in place is detected in the traditional way, but today we do have the possibility to transfer it in the CAD software.
And so we have a traditional interference in the treatment plan, but we are able to make it digitally thanks to the synchronizer. And so we are doing a very complex case. So we will need model and we will need the inclination, the proper inclination of the model in the articulator. And this is given by this.
But we don't want a digital model or traditional model.
I want a digital model. I don't know what you want. I want a digital model.
I don't want the traditional model. in fact, the laser-sintered model were then produced and oriented following the digital workflow sent to the model builder software. At this point, function can be then improved digitally and double-check it traditionally.
Obviously, we are not here saying that everything is perfect, because so far today we need still to implement the software library in order to get a better morphology for the functional occlusion. So we are not saying that everything is perfect. We need to keep working, we need to keep studying, and we need to keep improving. But we are almost there. We have everything there. You just need to get on this digital train and stay with us.
The cobalt chrome mesostructure and the monolithic zirconia crowns designed and produced together with the T-basis. What do we need now?
What do we need now? We have the materials, and you can see materials on full arch. That was the topic of our lecture, no? You have materials, we have the full arch. What are we missing?
We have little stones, no? In the hand. The master model, obvious, produced entirely with a digital workflow to cement the T-basis, obtaining the required passive fit, and to then cement the zirconia crowns on top of the structure, checking the overall digitally designed function.
And we described a cobalt chrome mesostructure, cobalt chrome framework, zirconia crowns, and look at the translucency. Look how the materials are evolving every day. Look what we can get. It seems lithium disilicate. It's great optical properties now, great strength, and obviously what will never be missed, and what is never going to go away is the artistic skill of the dental technician in order to merge perfectly the artificial pink component to the natural gingiva. That's another key. Don't listen to the dental technicians that are saying that digital dentistry is going to take away their job, because they are not. They are not at all. And you see, at the end of the story, we have our patient that is a doctor that right now is speaking about the procedure that he's going to do in 2 hours. And you see that we were able to bring this patient that had an advanced periodontitis from this stage to this stage in a completely digital workflow. We had one interference that was the traditional Facebook. But I'm sure that next year, in 2 years, we will be able to come here with a face scanner, with a digital Facebook, with a standardized and predictable full arch workflow to share together with you. Okay? So let's go and try to give you some takeaway message, since we are perfectly on time. That's strange. Actually, that's strange. I'm telling you, that's strange, but we are perfectly on time. So, what we said, digital scanning is providing us a lot of advantages: communication, management, ergonomic, so increasing the efficacy and efficiency. Obviously, we need digital model that must be produced in high quality. We must have a learning curve that is already now relatively fast for clinicians. And obviously the dental team must be up to date, because you saw how many changes are changing every year, how many things are changing month after month.
In maximum intercuspation cases, we already today have a reliable, completely digital protocol, while in full arches, we still need to define a consistent digital workflow.
Yes, because let's have a look at this last case that is doing the frame of our take-home method. You see, very complicated case, partial dentulism. So it's not always full arch implant rehabilitation. It's also, you can save teeth. They're not putting you in jail, so you can save teeth. Partial dentulism case, when you are finalizing the rehabilitation, once again, customizing the provisional restoration and using what? The possibility of copy and replicating what you have. That's the key of the combination of traditional and digital dentistry.
We can definitively state that new technologies are indeed a great tool to simplify the clinical and technical workflow. But we must not forget the traditional background.
Yes,
the
because
traditional background.
the traditional background is really the key in order to get the best out of digital dentistry. And the last sentence that we want to leave you with is that digital dentistry, don't think that is a trend, because nowadays every congress is digital. Everything is digital. Our book is digital, but it's really a useful tool. It's not a trend. It's a really useful working tool. And I really hope to see you very soon and discuss about digital dentistry in the future.
Thank you very much. Thank you very much.